All right. Good afternoon, everyone, and thank you for joining us for today's conversation. I'm Mary Nassett, Assistant Director for the UChicago Urban Network, and I'm going to be serving as the moderator this afternoon. Before we get started on today's conversation on racism and public health, I wanted to take a brief moment to share with you a bit about the UChicago Urban Network, which is a relatively new organization here on campus at UChicago. The mission of the Urban Network is to connect and promote scholarship, thought leadership, and experts across the country in the areas of urban policy, science, and practice. With more than 24 members from across the university, the Urban Network is focused on highlighting how faculty, staff, and practitioners in the urban space are confronting some of the most significant challenges of our time, as well as convening leaders in the field to share their expertise, which is what we are doing this afternoon. I'd also like to thank the Alumni Relations and Development team at the university who helped facilitate this event and engage the broader UChicago community in our work. This brings us to our conversation today. These past few months have revealed to a much broader population what many close to these issues have long known, that the acute problems of racism and healthcare in America intersect in ways that leave underserved communities sicker and now disproportionately impacted by a global pandemic. Joining us today for this important conversation are three women who are deeply ingrained in this work. Representative Lauren Underwood is a first-term Congresswoman representing Illinois' 14th District, the co-founder and co-chair of the Black Maternal Health Caucus, and a registered nurse. Dr. Melissa Gilliam, Vice Provost at the University of Chicago, the Ellen H. Block Professor of Health Justice and faculty in the Departments of Obstetrics and Gynecology and Pediatrics, and Brenda Battle, Vice President of the Urban Health Initiative at UChicago Medicine. Representative Underwood will be joining us shortly as she is currently in a committee hearing. So I would like to start by having Dr. Gilliam and Brenda expand a bit on my introduction and share more about the work they do before we dive into the conversation. Brenda, would you like to kick us off?
Certainly. So thank you, Mary, and thanks for this opportunity to speak along with Melissa and Representative Underwood on these issues that are important to all of us. So I'm Brenda Battle. I'm the Vice President of the Urban Health Initiative at UChicago Medicine and the Chief Diversity, Inclusion, and Equity Officer. And so in my role, it's really identifying complex health and social issues that the community that surrounds the University of Chicago is dealing with on a day-to-day basis and working in a collaborative model alongside community leaders, other healthcare providers, community-based organizations to solve those through interventions, research, and community-based programs. So our work is very much ingrained in addressing the issues of health disparities and health inequities, looking at how the social determinants of health impact the lives of individuals on the south side of Chicago, some that represent as patients at UChicago and many that don't. And so I'm very happy to be here today and talk a little further about the issues of racism.
Great, Dr. Gilliam.
Sure. So hi, and thank you so much for your introduction and for people being here. And it's such a pleasure always to share a stage with Brenda. So I'm a faculty member at the University of Chicago. I'm a professor of medicine and I practice obstetrics and gynecology. In particular, I focus on pediatric and adolescent gynecology, so children and adolescents and meeting their gynecologic needs. I'm also a researcher. I run a center called CI3, where we think about the health of young people, predominantly on the south side of Chicago, but also internationally, mainly around issues of sexual and reproductive health, and how do we engage young people as leaders and thinkers about their own future. And then finally, I'm a vice provost here at the university, and I work on issues, many issues around things like faculty development, diversity and inclusion, faculty recruitment, and a number of other issues that affect the institution. And so thank you.
Great, and thank you both for joining us today. I also wanted to let everyone know that you can submit questions through the Q&A feature down here on Zoom, and we will try to get to as many as we can toward the end of the program. With that, I'd like to kind of kick off our questions. So first off, particularly in recent weeks and months, Americans have taken to referring to racism as a disease. But a disease implies that racism is somehow a feeling that has infected people and not the very systems and foundation our country was built on. In preparing for this conversation today, we discussed how racism came first, before COVID-19, before even the modern US health system. In your view, what features of systemic racism have emerged as the greatest social determinants of health in Black and Brown communities?
So I'm happy to kick it off. So I think when you think about the answer to that question, you really have to think about racism in our country, which is why when we had this conversation earlier, we said racism started first before the impact that it's had on COVID and the impact that it's had on the health of Black and Brown communities in our country. And so in healthcare, racism is or healthcare is just another structure where racism has been played out in our country. And when we think about what systemic racism is, it's really about the policies and the practices and ideas, I'd say behaviors that get played out in our country. And it's most often played out in the form of race. Where privilege gets played out in our country is typically around the differences in race, and Black and Brown people are often kind of at the root of that. And so when you think of healthcare and how it got started in our country, well, it too is a structure, it's a system. It was also started based on practices and policies that were racist. There were two systems of care. There was a system of care for the poor, a system of care for the privileged, and often where care was delivered to the poor, they were Black and Brown people, poor people in general that were receiving care. And so when you've got a public and a private system, the system gets set up separately for the individuals that are covered through a system that's either public or private. And so when that is the case, then naturally those practices of care for those populations of individual are rooted in those policies that are particularly to address those issues. And so the root of that, to answer your question about what are some of the premier social determinants, is when you've got two systems of care operating in healthcare, then that's where your access issues show up. The public, under publicly insured, there's an access process for that, for those persons, and there's an access process for the privileged. In that, built in that are the practices, the policies that are racist policies that got started around healthcare. When you think of who's delivering care to the population, the lack of the presence of people of color in medicine, that's an issue that creates the evidence of racism in healthcare. When you think about divestment in communities, when you look at the north side versus the south side of Chicago, for instance, there's been a 72% more investment in healthcare north of Roosevelt, which is a dividing line between south and north and south of Roosevelt. So when you think of those kinds of issues, those things create racism. Those are systemic issues that result in racism. So I think that the compilation of how the system was developed is probably the biggest determination of why racism exists in healthcare in our nation.
So just to add to what Brenda is saying, so this idea of talking about racism as a disease is at an individual level versus at the systems level. And I always want to acknowledge that these are often big topics, right? I think people often hear, oh, the systems are full of racism, and suddenly it sounds like condemnation. But what they should be is actually helpful ways to start to think about how systems work and differentiate the individual. One of the reasons we talk about this in healthcare is that we actually have been able to document differential care at both the individual level, the way that individual physicians work. So for example, hello, Representative Underwood. So for example, we know for example, in cardiac care, that if a person of color comes to an emergency room and they say they have chest pain and they might need a balloon blown up in their coronary artery, the timing is often slower than if it is a white person. And that's the everyday decision making. So we know that individuals do practice these behaviors. By calling it a disease, you start to separate that from the individual themselves. And that's really important. This isn't necessarily you being a bad person, but because we have these blinders, we have these ways in which our reactions, the way that we think, it can affect our behavior. And so that's a really helpful way to sort of think about separating the practices and the behaviors from the individuals who you are as people. And by getting a little distant, you can start to rethink and act differently. But people create systems. And so those very biases and ways that we work also get entrenched in our systems. And just to build again on what Brenda said, when we're making decisions, they're not just in healthcare, they're outside of healthcare. So there's systems about who gets educated, and what type of education? What is the quality of your education? What is the quality of transportation? What is the quality? And all of those systems are built with some people having more access and better quality than others. And all of those things add up to create disparities that we see in healthcare as well, which is just another system. So think about it at the individual level, because that's also how we'll dismantle this, but also understand that these individuals are what contribute to these systems.
That's right.
Great. Thank you so much. And thank you, Representative Underwood, for joining us. I shared with our audience here that I know you are kind of busy with committee hearings and everything, so we really appreciate you making the time to speak with us today.
Well, thanks for having me.
Of course. So, you joined us kind of right at the beginning. Brenda and Dr. Gilliam were kind of speaking on some of these social determinants of health. And, I kind of shared a brief intro with our group about your work, specifically your background as a nurse, the Black Maternal Health Caucus, and how this is such a big passion for you and what drives a lot of your work. If you would like to kind of start, we'd love to hear more just about what it is about these issues that have kind of driven your work in Congress, and specifically about the Black Maternal Health Caucus and kind of the signature piece of legislation so far.
Well, thank you for the invitation to join you. I'm thrilled to be on this panel with these other experts. And you're right, this is my passion project in the United States Congress. I am honored to represent the 14th Congressional District, a suburban and rural community outside of Chicago, but I bring my full experience as a young Black woman to my job, and recognizing that Black women are 3 to 4 times more likely to die as a result of childbirth nationally than white women. And in our state of Illinois, Black women are 6 times more likely to die. These disparities have persisted my entire lifetime, and I'm 33. And so, I knew that when I got sworn in, this was something that I wanted to work on. There had been no national initiatives to try to address this longstanding disparity. And as a result, the United States continues to lead the industrial world in maternal mortality. It's something that in 2020, in the richest nation in the world, we shouldn't continue to struggle to keep our moms alive. So I teamed up with a friend and colleague. Her name is Dr. Alma Adams. She represents a community in North Carolina, to start the Black Maternal Health Caucus. And to be honest with you, we thought it was just going to be the 2 of us, but we gave ourselves a name because that's what you do in Congress. And the group quickly grew to more than 100 members. It's bipartisan, and we've had some early successes. We launched in April of 2019. And I just want to really emphasize that there is bipartisan opportunity for action here. In a time when gridlock in Washington is at an all-time high, and a lot of folks have lost faith in our ability to just get things done, we've seen this issue around maternal health and related disparities as one of the bright spots for collaboration and opportunity. We introduced the Black Maternal Health Momnibus Act in March of this year. So before everything shut down due to COVID-19, we had a big unveiling. And this is a bill that literally builds on existing federal legislation to comprehensively address the Black maternal health crisis in this country. It's 9 specific bills that have been compiled into one. I'm the lead sponsor in the House. Kamala Harris is the lead sponsor in the Senate. And I just want to describe a few of those 9 bills. The first is the Social Determinants for Moms Act. I caught a little bit of Dr. Gilliam's comments about social determinants when I joined the call, but this bill specifically would address higher levels of food insecurity that we're seeing during this COVID-19 pandemic by extending eligibility for the WIC program that provides supplemental food, healthcare referrals, and nutrition education for low-income pregnant and postpartum women and their children. The Social Determinants for Moms Act also addresses issues like transportation and housing and environmental justice, which we know continues to be a priority in this COVID environment, but really just when we think about the issues affecting Black maternal health. We have a bipartisan Moms Matter Act, which addresses maternal mental health and substance use disorder. And in particular, during this time of a pandemic, we see worsening mental health just across the country, an increase in substance use disorder. And I think that culturally, we found in the United States, people are very fluent in what postpartum depression looks like. But when we extend beyond depression to anxiety or substance use disorder, we don't necessarily see the level of expertise and targeted resources for pregnant and postpartum women. And that's become a key driver of maternal mortality, particularly here in Illinois. And so this is a bill that is a real focus of ours. The Kira Johnson Act, named after a woman, Kira Johnson, who died while giving birth to her son, Langston. The bill provides funding for community-based organizations that are on the front lines of supporting moms during COVID-19 and beyond. These community-based organizations have often been the sole voice speaking up for Black moms, raising the flag that this is a problem, and operating without federal funding or other targeted support to do this work. We want to lift them up, to champion them and provide them the resources for these really place-based strategies that we know are so successful. And then finally, the Perinatal Workforce Act, which invests in the growth and diversification of the perinatal workforce, ensuring that no matter where a mom lives, she receives maternal health care and support from people that she trusts. And it includes, beyond just physician providers, right? So nurse midwives, doulas. We want moms to have a choice and want moms to have congruency with providers that might share a cultural background or a linguistic background with them. And so that's something, so those are 4 of the 9 bills in the Momnibus. Now, recognizing that this COVID-19 moment is particularly challenging, we got some data from the CDC's MMWR at the end of June that showed that Black and Hispanic women were more likely to get severe COVID-19, which had negative impacts on maternal health outcomes. And so we wanted to really have a tailored solution during this time of a pandemic. And so I teamed up with Senator Elizabeth Warren to introduce the Maternal Health Pandemic Response Act, which addresses the unique needs of moms during COVID-19, improving data collection and research on the unique risks and effects of COVID-19 during pregnancy. This is important because Chicago and the state of Illinois really led the country in beginning and furthering this conversation about COVID disparities. But we have not been successful in the Congress to compel the CDC to release that disaggregated data by race, ethnicity nationally, right? We've seen partial data sets, really thanks to the efforts of the media, right? The New York Times published a data set of maybe half of the states, but even that has not been disaggregated by pregnancy status. And so it's really going to be important for us to understand COVID-19's impact on maternal health and then layering on the disparities that we know exist. The bill also has measures to ensure that therapeutics and vaccines are safe for pregnant people. And this vaccine conversation that we've been having and the distrust, the skepticism, the impact of the work of anti-vaxxers, and then even people who respect science and immunize their children say things like, we don't want a Trump vaccine. Well, there's a whole population of pregnant people that we need to even know if this thing is effective for. And so the legislation speaks to that. We offer protections for pregnant people in the workplace And then it calls for a task force to promote safe and respectful maternity care during COVID-19 and future public health emergencies. So, I know that people kind of hear the headlines about the delay in a COVID relief package, the way that the conversation has kind of shifted beyond COVID disparities and the healthcare needs of the virus and this, focus around political conflict or the economic impact of the virus. But I want you to know that there is a group of us who are very focused on these disparities and the impact on maternal health in particular. Thank you.
No, thank you. And we've actually had kind of an audience question related to that, especially the perinatal care. And this is something that I know Brenda and Melissa could speak to. As you might have mentioned, American Black women die at 3 times the rate of white women in childbirth, and Black infants are almost 2.5 times more likely to die than white infants. And just last month, this new research revealed that the mortality rates of Black infants shrunk significantly, up to 58% when they are cared for by Black doctors.
Right.
And so, I don't know, Dr. Gilliam, if you want to speak to, what this tells us about our health system and how this can improve health outcomes.
Sure. So first of all, I want to say that it's one of those things where everything, these are not new findings. This is something that is quite old knowledge that now once again seems new now that it's put in yet another study. And the reason I say that is that these are findings that go back to, 2003 was the first time the Institute of Medicine wrote about separate but unequal care. And then, as you all probably also know, that in 2003 there was a Sullivan Commission which basically said that we have to, again, this was a bipartisan issue, that we have to have increased diversity in the healthcare workforce. And so here we are almost 2 decades later, understanding this. The reason that this gets attention and the Sullivan Commission was even created was because diversity of the workforce was considered and has been a known strategy for improving healthcare outcomes. I think it's probably a couple of different things, and the authors of the article that you're citing also say that it's a number of things. One is that when you have systems that are in place where you can hire a diverse workforce, those are systems that are thinking about equity. And so I think that is a really important point. But we also know that people who come from these backgrounds that are traditionally underrepresented are more likely to practice, to provide care to people who are low income and underserved. And so that's a really important place. Where do these people practice and where do they go? But then we also think at the interpersonal level, we are significantly less likely, if you are a person of color and have that experience, you're less likely to introduce those same levels of potential areas of bias or potential prejudices into healthcare. What was interesting about that study is it showed that for physicians who were Black, there was no difference in the outcome for white patients. And so again, this is it shows you the importance of having diversity in the healthcare workforce. I talked to you about these are studies that went back in for quite a while. For a couple of decades now, we've known how important it is to have a diverse healthcare workforce. And unfortunately, despite all of the efforts, we're still not there. We were talking earlier today in terms of the few primary care practitioners, the few Black physicians who are in that primary care workforce. Even at our own institution, Representative Underwood talked about the mental health care and the importance of having providers of color who are providing mental health care. There's certainly many more people of color who are practicing OBGYN compared to some of the other fields, but still it's certainly not enough. And so we know this, we've known this for a long time. And so we shouldn't think that when we diversify, when we have increased diversity of our healthcare workforce, it's not only the moral thing to do, but it is the right thing to do because we change health outcomes.
Yeah, and the only thing I'd like to add to that is that even when you look at the data for the mortality rate for women that are Black and are better educated, a higher socioeconomic class, that the outcomes are still worse for more, I'd say, privileged Black women in that case. So the idea of having a more diverse workforce is essential, and it doesn't mean that individuals that don't represent the same race or ethnicity of the patient population can't also deliver good and equitable care. That is absolutely possible. There is an element of cultural competence, understanding of the race dynamics, the social political dynamics that communities face, that's important in understanding how to address some of the needs of patients that are being cared for by non-diverse persons of colors in those treatments. But to Melissa's point, it's essential that our workforce is representative of the population that we are caring for. And in that combination of a diverse workforce or more culturally astute workforce, I think that's what helps gets us to the better outcomes, regardless of the boundaries around socioeconomic class for individuals that we serve.
And if I could just add, I think that the diverse workforce plus a Medicaid expansion, right? Like we do those two things and you make a dramatic difference in the maternal mortality and severe morbidity rates and the disparities that we see, particularly for Black women in this country. As we know, Medicaid pays for 66% of Black births, 43% of all births in this country. And, you know, when we look at the states that haven't expanded Medicaid, we're seeing that their coverage cuts off 60 days postpartum. And so if there is this incongruency, or quite frankly, just a lack of maternal health care providers, which is so often the case, an incongruency between or not diverse workforce, and then absence of coverage for that pregnant person or postpartum person, then, you know, we're setting up a scenario where it's not a surprise that we would see these negative birth outcomes. And so that's why we were so pleased in the House of Representatives to be able to pass a version of Congresswoman Robin Kelly's Helping Moms Act to expand postpartum Medicaid coverage to a full year postpartum in the recent ACA enhancement bill that passed the House in June. So I think that there is a payment piece or a policy side of this in partnership with diversifying the workforce that would make a huge difference.
Absolutely.
Yeah, just to jump in there, the difference between practicing post-ACA and pre-ACA, when you are trying to provide care and you know that 6 weeks after a person delivers, their healthcare may be cut off, that they will no longer be insured, it actually makes you start to adjust the way that you deliver care, knowing that you may be able to prescribe this medication versus this medication or nothing at all. It actually starts to make you adjust the way you provide care according to the insurance. So these are the most important things, even whether you'd be able to see a patient or see them again versus other people who've had the exact same physician who knows all of their history, the exact same healthcare team for 10 years. Just think about the difference in quality of care. So these questions about insurance and the expansion of coverage are just essential.
Yeah, and I think to your first question,
Brenda, I'm so sorry to cut you up, but Representative Underwood, I know you have to get back to your hearing, so we've taken up a lot of your time, so I just want to thank you so much for joining us, and we will be continuing this conversation here with Brenda and Dr. Gilliam, but I wanted to make sure you can get back to your important work.
Thank you, ladies. Such an honor to be with you today.
Thank you. Same here.
Yeah. So sorry about that, Brenda.
No, absolutely. Yeah, no, the only point I was going to make, your first question is about healthcare systems and the determinants that impact Black and Brown communities. I think this whole issue of with Medicaid early on, and most of the nation, after that 6 weeks postpartum, at that point, moms have to either enroll in Medicaid or a different type of insurance if there's that ability. And if it isn't, if that doesn't happen, then her coverage drops. And when her coverage drops, care postpartum then drops or gets delayed because she either has to switch providers or she just doesn't get care at all. And what we know from the data is that the majority of deaths postpartum happen not within the first 60 days of delivery, but after between 61 days and 364 days. And so when there's not care in that period, then that's how the mortality rate for women, particularly women of color, Black and brown women, that's one of the reasons that it's so high, given 43% of deliveries are covered by Medicaid. So it's a significant systemic issue that needs to be addressed at a national level.
Yeah, and I think, you know, taking it from the national and bringing it here to kind of something specific happening here in Chicago. And Brenda, I think you'd be great to speak about this. You know, we've seen in the past, just in the past few months, we've seen the announced closures of hospitals like Mercy Hospital in Bronzeville and the shuttering of maternity wards at hospitals like St. Bernard's and Englewood. What kind of impact is this having on these already hit communities, and how do we reverse these trends that we're seeing?
Yeah. So, you know, yeah, obviously in communities that are already hit by high rates of disparities, like in Chicago, and Black and brown communities in Chicago, we've already talked about the maternal and mortality and morbidity rates. But when you think about diabetes, it's 4 times higher, but diabetes-related deaths is 4 times higher in Black and brown communities than they are in white communities. There's actually access to, Representative Underwood mentioned this, there is 29% less access to prenatal care on the south side of Chicago compared to the rest of Chicago. And on the south side, we've had 7 hospitals at one point that were doing deliveries, and now with the closures of maternity wards and the potential closure of Mercy Hospital, we're gonna get down to 2 hospitals that are delivering. So when hospitals and programs close at hospitals in already in communities that are already suffering high rates of disparities, then that creates a tremendous issue of impact in terms of healthcare access. In the south side of Chicago, where there's about 650,000 people living and very little access to hospitals, 1 academic medical center and 5 community hospitals, this is going to be a tremendous impact in terms of access. We already see that about 60% of our community migrate out of the south side for care because of issues of access and quality and a number of issues that if there is not in the care in the community, then the people obviously suffer even greater. So things that need to happen is, 1, there needs to be a better investment in healthcare in communities that already are deserts, healthcare deserts. Particularly ours is the south side of Chicago. So that's, you know, obviously where my mind is right now. We know, I mentioned earlier that 72% more of the investment in the healthcare infrastructure happened north of the south side of Chicago. There has to be more investment, as indicated, on the south side of Chicago. There also needs to be consideration of how do we transform the healthcare delivery system on the south side. How do we do a better job of reducing the fragmentation in healthcare, linking the care that's delivered by community health centers or federally qualified health centers and hospitals that are on the south side, focusing more on wellness. How do you address the social determinants of needs? When you look at the data, and it's different in different places, but a lot of data says that only about 30% of the care is actually clinical care. The rest of it is what happens in the community, what enables persons to have good access to care, whether there's access to good housing, good education, food, jobs, those things that really enable a person to get care, to have better knowledge about how care gets delivered and what their ability is in terms of managing their own care. If you don't have access to that and healthcare doesn't have more of a focus on those sort of things, then the clinical infrastructure is one thing, and yes, we can continue to treat the issues, the illness, the disease, but we're not treating the well-being, assisting in the well-being of the individuals who need to have better health. And health, if you look at how it's defined, is not just the ability to not be sick or to be or not have illness. It is really the full well-being and the full scope of how we are positioned in terms of our well-being in society. So that's what healthcare needs to look at more. And then when you look at other countries, it's really the United States spends less of their dollars on public health. The other countries spend 70% of their health on these other issues that help promote well-being and good health, whereas we spend about 30% of our dollars on that. So those are the things that need to be considered when we're looking at creating wellness in communities in our nation.
This is, I completely agree with you. Just to add two additional components. The first is actually a reiteration of this emphasis on public health. As we know, that it's become very stark from looking at COVID, is that we have a defunded public health system. And as you all know, the public health focuses on prevention, and that is really the key to high quality health. Healthcare is always going to be more expensive once we're working on the issues once people get very, very sick. But in addition to focusing on public health, we know that the ounce of prevention, we know that the cost, the dollars, all of that it's a much cheaper, much more effective way. But the second issue is to get closer to our first question is around quality. And so what we know is that it is not just the presence of hospitals, it's the quality of hospitals and the quality of care. One of the people doing fantastic work on this is Dr. Elizabeth Howell. And what she did was she looked at the quality of care across the city of New York. Now she mapped this to prenatal care, to maternal mortality, as well as infant mortality. But people have seen the exact same thing when they looked at rates of COVID and death due to COVID. It is not just the hospital and whether you get to a hospital, but it's also the quality of that hospital. And what we know is that in general, hospitals where white individuals deliver have much higher quality, much better quality of care than those of where Black women deliver babies. And that if we started to address and adjust along issues of quality, we could actually really, really start to close health disparities around maternal mortality as well as infant mortality. So as we start to think about this idea of thinking about these cities as a system, where when you invest in one area versus another, that you're actually creating these inequities, and that as we start to think about healthcare, we should be thinking both of the preventive part systematically around issues of public health, but also quality across systems and how healthcare is delivered across systems. And so it's not just the pure availability of healthcare in that location, it is that high quality, error-free care in those systems.
Great. So we have about 5 minutes left. So I kind of want to wrap up into our last question. And this is kind of something we talked about when we were talking in advance of this panel. And there have been a handful of questions that have come in our Q&A around this same topic of, we have talked about these issues that are such a, systemic problem and these big challenges. And though these challenges are great, there are also a lot of required solutions to try to make healthcare work better for everyone, regardless of zip code or ability. So when it comes to solutions, kind of where do we start? And one question I want to kind of take from our Q&A is, what indicators do you see and can state that change is happening and could be sustained? So what are kind of these positive things we can look at after talking about these challenges?
I keep making Brenda go first.
Yeah.
I'll try this one first. So I appreciate that many of these questions get quite despairing, right? You sort of hear these. And part of it is because we do have such a good sense of indicators. We are a country that counts death, right? So we count maternal mortality, we count infant mortality, we count COVID death, and you can sort of see how these indicators, these public health statistics are much easier to track. And so it does, so we have a very good sense of public health indicators and outcomes, but kind of what needs to be done. So I think one of the most important things, and we haven't really discussed as much today, is the issue of engagement. It is critically important to engage communities in the solutions that will best serve their communities. Sometimes as researchers, we go, aha, did you know? We'll come back with something that is really profound, but actually quite obvious to anyone who is dealing day to day with the situation. So I think it is, I work with adolescents, I think it's critically important to engage young people. I think it is also for people who live directly in these communities, they can tell you. And they know what it is that is affecting them. And so I think this is really important because we often think about these as individual systems and we might think about healthcare, but if the most pressing thing to you is the education system or pollution in your local neighborhood, and these are the things that are impairing your day-to-day health, you are the expert in your situation. And we, as people who might have more access to power or money or resources, that is a call for partnership, but that leadership coming from members of the community about their own sense of well-being, I think is a really important part of how we will address and fix this. I think the other piece is still engagement, which is each of us we each have something we can do about this, whether this is voting, whether this is speaking out, whether this is when you have the opportunity to go to the fanciest hospital or take advantage of concierge service, you ask, why don't other people have this? You point out where this is unfair or where this is inequitable. These are just some examples, but I think this is engagement of people in their own healthcare, but I think it is engagement of all of us in questioning systems that continue to be inequitable. Finally, I think what we've seen in COVID is that we all are getting hit by these same problems, right? My well-being, I am not okay if you are not okay. If people in Alabama are requiring lots of testing, then those reagents are being used in Alabama and they're not being used in Chicago. So our well-being is affected. If you have a cold, another person has a cold. Now the expression is, when one population sneezes, the other one catches a cold, right? So, it's differential effects. But I think we are seeing how interconnected we all are. And I think, again, this is a call for engagement.
I will just echo what Melissa said. I couldn't agree more. I think that the only thing I'd add to that is we have to admit that we have issues in inequity in our country. And the only way to begin addressing them first is that we first admit that they exist. Because if we don't admit it, then we won't even seek to find an opportunity to use our leverage, use our privilege to address those. And I think engaging in these sorts of discussions, learning more about, what the realities are that we face, maybe opening up one's consciousness to it so that they can actually leverage their abilities to participate or engage in how these things get addressed is important. And I know we're out of time, but we have some great examples. And one very quickly is just the reality that Chicago, Illinois has done a bit better with its COVID. Yes, we had a great surge in COVID positive testing. We had communities that didn't have, that were more greatly impacted and didn't have access to tests and PPE and the necessary supplies. And Chicago came together, Illinois came together around addressing that. And that positioned us pretty well with the growth of COVID positive in Illinois. And we're not the worst state. We're somewhere in the middle. And I think the effort that was put into the communities that were hardest hit, and these were Black and brown communities, helped to actually render us in a better position than some of the other states around the country. So that's a perfect example of knowing that it's impacted, knowing that there are inequities, and then leveraging the resources and collaborations together to address those. There's many, many stories like that to tell.
Great. Well, I think that's the perfect note to end on. So I want to thank everyone for joining us today, and a special thank you to Dr. Gilliam, Brenda Battle, and obviously Representative Lauren Underwood. We so appreciate you all taking the time to discuss such important issues. And for everyone who's joined us today, if you're interested in learning more about the work of the UChicago Urban Network or seeing the video from today's conversation, you can visit urban.uchicago.edu. So thank you, everyone, and have a great afternoon.
All right, thank you.